Have you ever had left lower quadrant pain? Could you actually have diverticulitis or diverticulosis? Well, today we're going to talk about the top 5 things that you should know about this disease process. Are you at risk? How to diagnose? And what treatment should you actually get? Let's dive in. Before we dive in any deeper, we have to understand the terms that we actually utilize. First is diverticulosis and diverticulitis. What's the difference? Well, diverticulosis is basically an outpouching in the colon. This is actually a pseudodiverticulum. Compared to a true diverticulum, where all the layers of your lining, including the mucosa, submucosa, and muscularis, is actually within the diverticulum, in a pseudodiverticulum, you only have the mucosa and submucosa going through the muscularis. So it's basically thinner and more likely to perforate. When it does, then you have an inflammatory reaction, and that's what diverticulitis is. The incidence is actually 180 per 100,000. It's more common in males younger than 50 and in females above 50. The incidence actually increases as you age. So better get that screening colonoscopy at the age of 45, because at the age of 60, your chances of getting it is actually between 30 to 40%, and by the time you reach 80, it's now actually up to 65 to 80%. If you have diverticulosis, what are the odds of you actually getting diverticulitis? It's actually 5%. But how do you present? Complicated? Uncomplicated? What's the difference? Well, if you only have inflammation within the colon, then it is uncomplicated. Versus if it is complicated, which include abscess formation, obstruction, fistula formation, and free perforation. We actually utilize the Hinchey Classification, which is graded into 4 different categories. The first one is a pericolonic abscess. Grade 2 is pelvic or retroperitoneal, which is more distant abscess formation. Grade 3 is purulent peritonitis. And grade 4 is feculent peritonitis. 75 to 85% of all diverticulitis are actually uncomplicated, which is the good news. So what are the risk factors that we have to consider when patients actually present with diverticulitis? And how can we improve those? There are actually 7 known risk factors. 4 are actually modifiable. 1 is actually smoking. Number 2 is NSAID use, corticosteroids, and opiate use. If you could avoid those, you can decrease your risk factors. A higher BMI, so better start getting more active. And with increased activity, you actually have a lower risk of diverticulitis. Also, when you have a decreased activity, you have a higher chance of getting it. What are the non-modifiable factors? There's 3. One is going to be any collagen disease. And if you have HIV, that's also a risk factor because if you're immunocompromised, which makes you more complex. And lastly, another set of immunocompromised patients are patients with undergoing chemotherapy. Diverticulosis sometimes is diagnosed selectively when patients are undergoing colonoscopy, and this is how it looks. However, when they do present with diverticulitis, a CAT scan is usually of paramount importance because it differentiates whether complicated versus uncomplicated, and that determines what treatment you're going to get. So what are the things that we have to consider in determining what the right treatment is? So for uncomplicated patients who are not immunocompromised, none of the risk factors that I mentioned, you can actually treat them non-operatively with bowel rest, and no antibiotics is necessary. Then who should get antibiotics? Well, the people who actually are complicated, meaning if they have abscess formation, depending on which Hinchey class they are. Is antibiotic sufficient? For abscesses less than 4 centimeters, it is actually sufficient. However, previously it was actually 3 cm, but now based on the data, there's actually up to 4 cm that you could treat non-operatively if it's not accessible, versus going in laparoscopically to drain them. Consideration would be if they're accessible and they're more than 4 cm, interventional radiology can do a percutaneous drainage to drain the abscess and provide source control followed by antibiotics. The success rate of this is up to 80%. But what if there's free air? Well, two types. Is there free air around the colon or somewhere else? And what you have to consider is the patient stable, unstable, and are they peritonitic? If they're stable and non-peritonitic, the free air can still be managed non-operatively with just antibiotics plus minus drainage if there is an abscess. However, what this actually foretells is the chances of the risk of progression and recurrence is higher. However, if the patient is otherwise peritonitic or unstable, then emergent surgery is necessary. If you had your first episode of diverticulitis, should you get surgery? And who are the people at risk of actually needing surgery in the future and has a higher risk of recurrence? Well, two things. One is the patient who is less than 50 years old. They have a higher risk of diverticulitis and recurrence. And number two is the patient who had more attacks. So if this is your second attack, you're more likely to have a third attack because it increases with recurrence. So considering surgery after your second attack is an option that you may want to consider. So going through the algorithm, you have to understand complicated versus uncomplicated diverticulitis. If they are immunocompetent, then you can manage them with non-operatively and no antibiotics and just bowel rest. However, if they are immunocompromised, you may want to consider antibiotics in that setting. If they are complicated, the marker for abscess drainage is up to 4 cm or greater for abscess formation and antibiotics. However, for people who are unstable, peritonitic, with either grade 3 or grade 4 Hinchey class, then surgery is going to be emergently performed. The two types of surgeries are going to be either a Hartmann's procedure, which is resection of the sigmoid colon and bringing out an end colostomy, versus putting the patient back together plus minus a diverting ileostomy. Well, when should you consider just doing a Hartmann's? The Hartmann's is more conservative as it completely diverts fecal stream. This should be performed in patients who are unstable and are septic. Postoperative complications can occur between 5 to 38%. And this is high in the acute setting, and that's why elective surgery usually is delayed up to 6 weeks to decrease the amount of inflammation. When performing the resection, the two important things that you have to consider is actually the margins to decrease the risk of recurrence. One is going to be the proximal margin, where you resect the colon. Do I take out all the colon with diverticulosis? The answer is no. You have to take it out only on the inflamed area. Number two, where do I take it out distally? It's better to take it out at the level of your sacral promontory at the junction between your colon and your rectum. A colorectal anastomosis has lesser risk of recurrent diverticulitis compared to a colocolonic anastomosis if you leave some sigmoid in there. It's also important to consider colonoscopy in the elective setting around 6 weeks or more to actually determine and ensure that there is no risk for cancer formation. Sometimes cancer can masquerade as a perforated tumor. Well, hopefully that answers your questions, which is what is diverticulosis and diverticulitis? Who is actually at risk? What is actually the treatment? When should we consider antibiotics? When should we actually consider surgery and how? All of this should be something that you can utilize in seeing patients and taking good care of them and making the appropriate decisions. If you guys like the video, please click like and subscribe. And basically check out the comment section and ask any questions. I'll be happy to answer them. And check out the video above. See you guys next time.